Administration and Monitoring. To speak on about topic, we have among us Ms. SaiBala M. She is Nursing Director, Amrita Institute of Medical Science, Kochi. She is a founder member, General Council member, and Educational Committee Chairman, Infusion Nurses Society, India, and she has participated as a resource person in various international and national conferences. I request you, ma'am, to please start the session.
Very good afternoon to all of you. Pretty late in the evening. Time for a cup of tea. I'm not going to have any presentation as such. We'll just probably share some stories of what we see around us. So, I'm not going to talk about any standards or guidelines as such. You can get all of those in your, if you go Google. So I'm probably trying to say what we see in our practice and what challenges we face when we talk about administration monitoring of drugs. We'll just go by the order of what NABH says in the third chapter, management of medications. The seventh standard in that talks about administration and monitoring. And the first thing is that the drug should be monitored by somebody who is competent. Now, there is a big challenge in India right now with this standard itself, because in major centers, like, in major hospitals, you may have people who are registered nurses, but in a lot of centers that I've seen in some smaller hospitals or areas where people are not really aware about the registered nurse and a non-registered nurse. They don't understand the difference between a diploma, a graduate, a non-graduate person. So the first thing is within nurses itself, the person who is allowed to practice or give medication is somebody with a practicing license. So that is active. Two things. One is that you are supposed to have a practicing license in that particular state. Right now, it's not a countrywide registration. You are supposed to have your own state registration. Second is that that person should be a registered nurse. Now, coming to the second part of the story, what do you do when you don't have a registered nurse? When you don't have a registered nurse, who else is authorized to do a medication? So a doctor with an MBBS degree minimum, or someone like you have a Pharm D. I don't know if you're allowed to administer medications, but someone who's anyway educated, not any random person, but there might be in community settings some JPHNs or junior public health nurse who are been allowed to practice under the supervision of a medical person, or there are certain drugs which are allowed by the JPHNs to be administered. Only those drugs can be administered by them. And then the rest is all. Another challenge is when you already talk about a person with a license, that you have a registered nurse. Now, what is this registered nurse learning in the 4 years or 3 years of her career? Education. So in 3 years, probably she learns about pharmacology, one subject. Sure, she learns about pharmacology, but then when you're actually practicing in a setting which is very small with a limited number of specialists, it's easy. But when you're practicing in a big center, major center, when you have multiple different department patients coming together, now the knowledge that a nurse has for administering drugs, especially high-risk medications, chemotherapy agents, those are, very, very limited. So competency does not just mean a license. Competency also means that somebody who's been trained to administer or monitor when your drug is being given. How do you monitor? What kind of monitoring is required? What kind of precautions are required? What is the what is the action? What are the major side effects that you watch for? That much awareness has to be there. But it's pretty hard to keep track of the amount of medications that one is asked to handle in terms of a nursing person. So that's a big challenge in today's setting. And automation and prescription through systems. Now, drug formulary is available for reference, because in a lot of times doctors prescribe in brand names. The nurses are not aware of that brand names. So you spend a lot of time trying to clarify. If you don't clarify, you end up giving totally different medications. Umpteen number of incidences, I'm sure if you start monitoring, you'll find out that the drug has been changed because someone thought that the drug is something else than what has been actually said. So this happens, and especially when there's a combination, like, an aspirin combined with A or M or something like that. They don't like, you have metformin combinations. Sometimes there are other many drugs with a combination. So when we are not about that one letter which is there and what it means, one letter doesn't mean it's just a letter, it's some other drug, it's a combination of drugs. So if you're not aware, if you're not really checking, you might get a lot of omissions. So this is a huge component of the competency of the person who's administration medicine. And then even if I'm competent, now what happens? I get a prescription. I don't understand what is written in it. Where do I go to check? Do I have a reference point? There is a formulary. Is there something in the system? Like whom do I call every time? Can you call a doctor and ask him what drug you've asked for? So that's where the role of a clinical pharmacist comes, where there is one point of contact where somebody is actually an expert in medications, and you can go back and refer to them and ask, like, really what is happening? Why do you really do? Is this what it's meant? This is what the patient condition is, or is this the way the drug is be administered, before food, after food? That's another clarification required. And then it's also the amount of prescription drugs that goes into one patient, and the medication order sheets. The medication order sheets, when it's manually written, in different hospitals follow different pattern. Some of them have a separate doctor order sheet, some have a different nurses sheet. So initially when we had that, the problem was somebody was transcribing the doctor's orders, that whole drug gets changed, the dose gets missed, the frequency changes. So there's a whole lot of errors just because of transcribing. So how can we reduce that? We try to bring the doctors and the nursing charting together in one format. Now there's another challenge came. You have a lot of stewardship. You have looking at antibiotics. You're looking at certain drugs which are highly, in a setup like Amrita, where you have general medicine to transplant to bone marrow, when you're trying to kind of standardize many things, there was a need for separation of certain drugs. So what happened was the SOS was separated, the antibiotics were separated. Now, if in such cases, if the nurse has to find out what are the medications due for at one particular point of time, either she has to transcribe, or you have to go through 5 different sheets to find out what's actually due for that one particular time. So it's a bigger challenge for us. Again, then also availability. That's where automation helps. Automation helps by, once you start entering the mistake, the errors of wrong dosage, the errors of drug being changed, the errors of not able to understand the connection between the brand and the chemical name, and the time that you spend trying to figure out what the drug is, reduced. So that's one way of eliminating a lot of challenges related to drug administration by computer based entries, or use of if you're actually rich enough, you can go into clinical decision making systems nowadays, where you can actually also get the drug to drug interaction, drug food interactions, so that you can actually make a better prescription and better administration. But expecting somebody at the bedside going to understand the drug interactions and drug food interactions will be humanly impossible in the setting that we work in as nurses. So second part of what NABH talks about is also patient identification. Now, that's another challenge when you don't really have the practice of checking the patient name and the two identifiers, either the name and the MRD number, or date of birth, or there's at least two identifiers same. The prescriptions get changed, and the bystander buys somebody else's medicines and come, and then by the time, if you're not checking, proper checking is not there at the time of administration, the right drug dose, route, patient, that is not happening, then there is going to be a lot of errors because of this lack of patient identification. Then the third thing is about medication identification. Again, medication verification, about the dosage, about the drug, about the route, the timing. And we talk a lot about the right timing, but in real practice, then somebody sends it to the pharmacy sends the drug back, the nurse has to find the time to administer. By the time actually the actual time of administration is passed. So what sometimes nurses do is they sign off and they forget to give, because they have to finish the sign off. And then how does somebody find out whether the drug is actually administered or not. So many centers, what happen when the nurse to patient ratios are low, what they do is they take the medicines out, put in a container, and give it to the patient's relative and say, you take it. So if some are before food, some are after food, and if that's not described, the patient takes everything together. Or you don't have the time to stand by and make sure everything is taken. So somebody just signs off saying that the medicine has been kept. You sign off, medicine given, but half the time the patient might not even have taken their medications. And sometimes when you monitor BP, when you're looking at the sugars, you understand that, something was missing. And if you're not able to identify double dosage again, sometimes they don't sign off that they give, and then you go back and probably administer again thinking that the medicine's not given. So that's another challenge when you really don't identify the patient, verify and document it properly as and when is given. Then the next thing is about labeling, like you have multiple injections to be given in an ICU setting, especially when there are multiple drugs and you're kind of withdrawing. If there are, if in our setting we have pediatric cardiology which has maximum support, there are at least 5 to 6 drugs going in very very small volumes. So each of them are loaded in small 10 cc syringes, and if you don't label them immediately after you dilute, the chances of you mislabeling is high. And the incidences of wrong drug being administered because the labeling was wrong is also very high. Maybe it can even be lethal, because at times when you are storing these drugs for emergency, they get misplaced as a common drug or an inotrope, and there's been pushed, and then the patient goes into lethal effects because of the wrong drug. And also the right kind of labeling, legible drug dosage is another big challenge, especially in pediatric and neonatals, especially premature babies. The availability of certain drug at pediatric dosage is not there. So what we have to do is, we are supposed to, maybe 20 milligram drug is available, or 5 milligram drug is available, is still okay, but 20 milligram, 10 milligram drug, the baby needs only 1 milligrams. How do you change the 20 milligram tablet into 1 milligram dosage? It's actually, I think, I don't know how much we think about the challenge of person who's administering the drug. The doctor is prescribing, thinking the nurse will somehow manage to give the dose. Everybody expect the nurse to calculate, but then we have to have the drug being diluted into something. Then again, what is the volume to be taken? Actually, when you're diluting a tablet in a solution, are we getting the real therapeutic value of it? I don't know if anybody's actually checking those details. And especially when you're having to dilute for, this like 0.4 milligram uh, given, like, some drug which is like really really minute volumes. How does the nurse know how to dilute it in a bag? Most of the nurses go to nursing because they don't have to study math. But you end up landing to calculate a lot of drug dosages which are beyond sometimes somebody's intellectual capacity also, because especially in the pediatric and neonates. So again, there is a need for clinical pharmacists helping with, in the western countries, how they manage this is they have dedicated pharmacists who dilute these drugs to make sure the dilutions and the therapeutic, whatever therapeutic level needs to be achieved, is being given. That is a big challenge in India, especially when lower dosages are. No, one is availability. Second is the whatever is available to convert them into the dose that is required for the patient. Now, another thing is, we talked about strength, route, and verification. The next is labeling. We talked about labeling. Then there is another challenge. We have multiple catheters. You have the IV, you have the arterial lines, you have the epidurals, you have the into intestinal enteral feeding tubes. So there are at times when the tubes and are not labeled, you can connect it wrongly to some other tubing. So instead of the IV going, if the IV goes into oral, it's fine, but the oral goes into the IV, then you had it. So, and sometimes when you're actually giving NG feeds, you've powdered the oral medications, and that goes into an IV line, then you are in major trouble. And sometimes the oral, usually in tap water, so it's not sterile fluids. And then sometimes you can actually, when you're supposed to put it's something through a pump, and the volume has to be restricted, and you put the pump in a different port, and the other IV set into a normal without a pump, and then in few minutes a huge volume of fluid just goes in, so creating lower fluid overloads. And sometimes if it's a potassium or some other drug which is high alert, need to be monitored, then you can have a very lethal effect which is possible. So then the next thing is, so what do you do? We have to actually look out for, you have to trace every tube, you have to make sure they are labeled at the both the ends, the distal and the ends, and at the every shift every nurse is actually supposed to trace back all the tubings from the beginning to the end. And whenever there is a reconnection, whenever there is, when you're actually taking them out, you need to make sure they go into the same port. So the ports have to be labeled, the tubes have to be labeled at both the ends, where it's going to the medication and where it is going to the port, the tube. So that's another major thing that the nurses have to watch for, especially when you're having a lot of lines and tubings being placed on your patients. Then next is about documentation. There's whole lot of we have already discussed during the entire course, that plenty of documentation that goes into the biggest challenge would be to have all the documentation in one place, so that we can actually reduce the transcription kind of errors. And also in West, what happens is most of them, when it's computer based entry, someone is actually watching to make sure the due time drugs are given. So that's easier way to do it, because if somebody is missing out, like, in a huge setting where everything is manual, the head of nursing or the in charge or the supervisor, whoever is responsible for the unit, they may not be able to go and check every patient's medicines are given on time. But in when it becomes a system based entry, and then the administration monitored, there's a system where you can actually sit in your office and look at how many patients medications are due and how many have been already administered. If you really follow the practices, that is the best thing you can have, because you can be very sure that timing is being done. Now, documentation not only includes administration of medication, it's also include the whatever we talked about, adverse events, talked about medication errors, identification and reporting, so that you can control these kind of errors. The next will be, in any hospital there will be patients who come with their own medications, so we have to have a policy to make sure that how the hospital defines self medication. And also there will be some patients relatives who are very happy giving their patients medication, because they are very familiar with it. So the thing is, you also need to follow make a policy of what do you do with self medication. What is a policy if the patient wants to bring the medicine from outside? What is a policy for that? These two policies need to be made in every hospital, in terms of, so these are some of the aspects. And we already discussed about prevention of medication errors, where we looked at look-alike sound alike medications in every unit in a hospital. The nurses, it'd be nice if the nurses, it's an actually very best practice to have a look-alike sound alike list and being pasted. And also I think it comes on nurses to go back to a certain extent, where we feel the highest challenge of picking up the wrong medication. Especially when I remember we used to have this 3% hypertonic saline and atropine in the same container. It looks the same, and then instead of many a times 3% saline atropine was administered to patients, and we never knew. Like metrogel, ciprofloxacin, and 100 ml saline, they also look the same. So if you don't look at instead of giving 100 ml domperidone saline, you dilute the drug in metrogel. So those things have happened. Yeah, I think times have. Yeah. Time's up, I know. So this is all about administration, a few challenges that I'm talking about. And then next is about monitoring. So monitoring will come, like we've already discussed in the earlier sessions, about therapeutic index for drugs which are having a very narrow therapeutic value. And especially the most common ones like potassium and insulin infusions, and there are drugs which really require monitoring. So nurses should take a upper hand in saying that if there is a monitoring required for the drug, the setting has to be adequate enough for the monitoring to take place, because if there are more less nurse to patient ratio and the drugs being administered, the chances of the drug being monitored, the effects of the drug being monitored, and preventable consequences being warded off might not happen. So it is upon the nursing to bring up to the administration or whoever, or the physician, saying that this particular drug needs monitoring, and we don't have the facility, we don't have the intense nursing that is should be available. So please make sure that the patient goes to a unit where this can be possible. So that is another thing that nurses can actually do to prevent a lot of errors. I think I won't take much time. I think I've done some decent job on covering the basics of administration and monitoring. Thank you for giving me the opportunity, and hope you're not been sleeping off through the session, though it's a late in the evening time.
Thank you, ma'am. Thank you for your valuable session.